Hi, my name is Ben Goldacre. I run the Data Lab at the University of Oxford, and we're part of the collaboration that built the OpenSAFELY analytics platform. We're really keen to see as many people as possible working with the detailed electronic health records that underlie the OpenSAFELY analytics tools. But we're aware that there are people, in particular in the operational research community in the NHS, who've not previously had access to this data. Now, this is quite complex and interesting data. It wasn't produced specifically for the purposes of research. Electronic health records are doctors' notes. They're produced for the purposes of direct patient care. And so processing them into research-ready data sets requires a degree of familiarity and understanding with how all of those data sets work, how they're produced, what their original purpose was. Luckily, there's a fantastic history of people doing work of this kind in the UK, and we've assembled a group of 4 people from the Electronic Health Records Research Group at London School of Hygiene and Tropical Medicine to run through some of the basic aspects of how this data works and how it differs from HES or SAS or the kinds of data sets that people may be more familiar with. So coming up, we've got Helen MacDonald talking about how this data gets recorded in primary care. What happens in the consulting room when a doctor sees a patient, when they talk about their problems, how that gets coded into the primary care electronic health record. Next, we've got Stephen Evans talking about how you might create variables in your data set to describe whether a patient has or has not had a particular drug. And we'll be getting into some of the weeds of how prescription data is recorded and how it can be converted into research-ready variables. Next, we'll have Kevin Wing looking at how we describe clinical aspects of patients. So, for example, a health outcome, how you identify whether a patient has a diagnosis of a particular disease or whether they've had a particular event that's associated with an underlying clinical problem. And then finally, we'll have Ian Douglas talking briefly about how you can do research using electronic health records, so how they're used in traditional electronic health records research programs, for example cohort studies and case control studies. They are the A team for this kind of work. It's really important to recognise that electronic health records data from primary care is not like other forms of research data sets or administrative data sets. It was created specifically for use by clinicians to record information about their patients. And as with most large data sets, there's a risk. It's very easy to deliver not very good research very quickly if you don't understand the bear traps. So this, I hope, will be a useful 50 minutes to cover off some of the basics. Before we get onto that, let me tell you very briefly about OpenSAFELY, and if you feel like you already know this and it's been done to death elsewhere, then skip forward the next couple of minutes. So OpenSAFELY is a completely new kind of secure analytics platform for electronic health records in the NHS. It was created to develop urgent results during the COVID-19 emergency, and it's now successfully delivering analyses across more than 24 million patients' full pseudonymised primary care NHS records, rising soon to 55 million. It's unusual in various different respects. First of all, it's all script-based. All our analytics software is fully open and shared. So it's shared for security review, it's shared for scientific review, and it's shared for efficient scientific reuse. That's really important. Health data research in the UK has been held back by closed working methods and a tendency to work in silos behind closed doors. We think that sharing code and code lists is really important. Firstly, you can find sometimes that there are shortcomings in the code lists that other people have used. You might find, for example, that ocular hypertension is included in a list of codes used to identify people who've got hypertension. It's also really important because, as well as spotting problems, you can spot opportunities to improve code, but also opportunities to reuse code. For example, every time we do something once in the OpenSAFELY framework, it's a pain. It's a lot of extra work. But having built that template, having built that code base, we can reuse that code really efficiently. And that's true for the specific analyses or graphs or tables that people might want to produce, where we're rapidly turning those recurring jobs into libraries that can be done with single line commands. But we're also doing the same for the process of curating the raw underlying data into research-ready variables, research-ready data sets. taking the whole journey that you're about to see of converting the raw underlying electronic health records events into simple assertions, features of individual patients. We think that once that's been done once robustly by one group, it should be shared in standardised ways, leaving behind a good a good library of curated transformations of the data to help everybody do all of their work quickly and more efficiently. We think that the community is really hungry for that. We hope that you enjoy working in that way. Let me run through a couple of quick sites that you might find interesting and useful. First of all, at OpenSAFELY.org, which is growing all the time, you can find not just a summary of how OpenSAFELY works, but also our research and information about governance, contact, press coverage, and so on. If you go to our GitHub at github.com/OpenSAFELY, you can read all of the code for both the platform and all of the analyses that have been run inside the platform. If you go to docs.opensafely.org, you can see the full documentation for everything in OpenSAFELY. So that gives you everything you need to know on how to drive the platform. That's outside the scope of what we're talking about today, but if you're interested, we have other videos and other content online. That's an example of how you write study definitions and convert data, underlying raw event data, into research-ready variables in OpenSAFELY. This is from Will Hume in our team, an example of a Jupyter notebook that takes you through the full workflow of taking the raw data and then converting it into tables and graphs that look like this across the whole country. And then lastly, this is our paper published in Nature, the first output of many from the OpenSAFELY platform, showing the factors associated with risk of death from COVID-19 during the pandemic. So, on with the show.
Hello, my name's Helen MacDonald. I'm a clinical epidemiologist and I work for the NIHR Health Protection Research Unit in Immunisation. In this session, we're going to look at how and why data are recorded in primary care and how that shapes what data are available in OpenSAFELY primary care records. As you'll know, with any secondary data analysis, it's really important just to ask about the purpose of the original data collection. Who is included in the data set and who is not, what information is recorded and why, and how that data has been recorded. Then you can put all that together to consider how the recording of the data in its context might be relevant to your study question. And this session will aim to help you do that when you're using primary care data in OpenSAFELY. So the main purpose of primary care records is to support direct patient care. This makes quite a big difference from administrative data sets, such as hospital episode statistics. It means that the context of the patient's illness is very important to what data are recorded and how. It makes them very rich and valuable data sets for research, but also quite challenging to use. In the UK, anyone can register with and access primary care for free. However, in practice, there are particular groups who experience barriers to accessing primary care. So while 99% of the population is registered in primary care, or almost 99%, it can be particularly important if you're working in exclusion health to be aware of the barriers that particular population groups can face to accessing primary care. So let's look for an example consultation at what happens with information recording in primary care. As an example, we'll take a small child who's taken to the doctor with a fever and a rash. The GP can pull up the child's medical record electronically on the computer and see what the child's had previously, including their immunisation history and any previous illness. They're going to take a history from the parent and the child and examine the child. And there's a great deal of information that will be gathered in that process. In this case, they examine the child and they see that the child has a sandpaper rash and a peeling tongue that looks a bit like a strawberry. And both of those are very characteristic of a bacterial infection that's called scarlet fever. And so in the notes in the free text section, they'll type what they found, their main findings, both the positive ones, such as the strawberry tongue and sandpaper rash, and also the negative findings that are relevant to why they think this isn't another diagnosis. And in particular, the GP is likely to be concerned to record that they have assessed whether the child has any signs of sepsis or meningitis, and their assessment and the rationale for why the child is well enough to be treated in the community. All of that goes in the free text. And then the GP might record some structured data. Now, some GPs will record symptoms in structured data and others won't. In this case, you might say, I'd like to record the rash. But if you start typing sandpaper in, you won't find a relevant rash code for scarlet fever, sandpaper rash. But you might choose to record that it's a blanching rash as evidence that you've considered a meningitic type of rash. And you'd also start typing in scarlet and select from the drop-down options a diagnostic code for scarlet fever. As a next step, scarlet fever is treated with antibiotics. Prescribing in primary care is electronic, and so the GP will use the electronic health record to generate an electronic prescription, which might be printed out and given to the patient or sent directly to the pharmacy. In this case, they're likely to prescribe penicillin B, and that will be recorded again in the structured data of the electronic health records with prescription data. Now, for some prescriptions, the dose will be recorded in that structured data. For others, the GP might select an as-directed option and then free type in particular instructions to the patient, such as, this medicine's very bitter, try giving it with chocolate milk, in which case you might find that the dose information is missing. But this isn't the end of the consultation. The GP and the parent are likely to discuss the parent's concerns and how best to look after the child. A GP might advise making sure that the child drinks plenty of fluids, takes paracetamol, hygiene measures to prevent spread, exclusion from nursery until the child is not infectious anymore, and safety netting advice on things to recognise if the child's becoming more unwell and needs to return to be seen again. Now that again was likely to be recorded in the free text and there isn't really a way of recording that in structured data. But the paracetamol advice is perhaps a good example of the kind of data where recording varies according to the patient and over time. Not that long ago, it might be that a child would receive a prescription for paracetamol solution. Although paracetamol can be bought from the pharmacist and is very cheap when you buy tablets for an adult, it's more expensive to buy the paracetamol solution, and children are exempt from prescription charges. And so it might have been that people who are exempt from prescription charges might still have received prescriptions for drugs such as paracetamol, which can be bought directly from the pharmacist. However, there has increasingly been guidance about prescriptions of paracetamol and other drugs which can be bought over the counter, and clinical practice in this respect has changed over time. And so in current circumstances, it's very unlikely that a child would have a prescription for paracetamol. While discussing nursery exclusion advice, the parent mentions that actually another child at nursery has similar symptoms, and this raises the question of whether there might be an outbreak. The GP might consult the public health advice for scarlet fever outbreaks at this point and discover that in the case of outbreaks, even though scarlet fever can be diagnosed very well clinically from the signs and symptoms, it's advised to send a throat swab to test for the bacteria to confirm the diagnosis, since this diagnosis might then affect other children and their attendance at nursery. So the GP might take a throat swab and send it off, which a few days later, the result arrives electronically directly to the record and is uploaded as Group A Streptococcus. And this is another example of how the context of an illness can affect the recording. So you might only find that microbiological confirmation of a scarlet fever diagnosis is available in the context of children who go to nursery and have had an infection in the context of a potential outbreak, rather than all cases of scarlet fever. Finally, scarlet fever is a notifiable disease, and so the GP is going to send a public health notification. In the case of a single case, they might have sent this by a secure email or even a fax. neither of which would be likely to end up in structured data, although there is facility to record as a code that you have sent a public health notification for scarlet fever. In this case, because there's concern of a possible outbreak, they might phone it through, and so that information would probably be recorded in the free text that they have called, but there would be very limited information available in the structured data, and researchers probably wouldn't be able to see that there had been a notification from that. And so you can see that of all that very rich and long consultation, discussion and advice, a very limited selection of that information becomes available in the structured parts of the electronic health record, which is what researchers will be able to see. And of that information, it's been driven by quite a number of factors. So some factors which influenced what information was recorded were, for example, medical legal considerations about wanting to record that there had been an assessment of whether the child was septic and whether the child might need to be cared for in secondary care rather than the community. There's also the wider context of the illness, that there was a query of an outbreak, and so microbiological tests were sent. A lot of information was lost from two steps. First, the conversation between the GP and the parent and what gets recorded in the records. And secondly, a lot of information is recorded in free text rather than structured data, and is thus unavailable to researchers using structured data such as OpenSAFELY. And finally, we've looked in a bit of detail at what information is recorded from a consultation and why, but whether the consultation happens is also dependent on many factors. So not every child will attend the GP with every fever and every rash that they have. And the factors that determine whether this child is seen with this illness and whether they're diagnosed might depend on factors such as barriers to primary care for that family, awareness that scarlet fever is an illness that should be treated with antibiotics to prevent complications, and perhaps other factors such as where the child is at the time, whether they're at home, whether they're seen as a temporary patient somewhere else, or whether they're seen at their usual GPs. Another factor which can be important for other patient populations is that while you're admitted to hospital, you're not collecting your regular prescriptions from primary care. And so there are many factors in where a patient is that might determine whether a particular episode of illness is captured in the primary care record. Finally, we're just going to have a little look at the coding of ethnicity. So this graph shows the proportion of patients who have a valid record of their ethnicity in their medical records. We can see that this considers hospital care, HES, and a primary care dataset, the Clinical Practice Research Data Link. Let's look at the line which is in the darkest blue with diamonds, which shows the recording of ethnicity in primary care as recorded in the Clinical Practice Research Data Link. You can see that ethnicity could be recorded for quite some period of time, but was recorded only at very low levels for many years. And then there's a sudden increase for 2006. Now that might seem at first baffling unless you know that the recording of ethnicity was financially incentivised through the Quality Outcomes Framework for 2006-07, and that lasted until 2011. And you can see that it had a really massive effect on the recording of ethnicity in primary care. And so you can imagine that if you were doing a study where ethnicity was important, which covered a longer time period, you might find that there were differences in who had ethnicity, in not just the completeness of the ethnicity recording, but also which patients had their ethnicity recorded, and that those might particularly have a big change at the point at which the Quality Outcome Framework was introduced, and possibly also at the point at which it was removed. The other lines on this graph show ethnicity recording in hospital episode statistics from secondary care. And in this paper, Rahini Mather also shows that you can combine these two data sets to get better completeness of ethnicity recording among the patient population by linking the hospital to the primary care record. And so what we've been looking at is how the coverage, content and purpose of primary care records shape what questions they can be used to address, what patient groups they cover, and are very important to take into account when you're designing and interpreting a study that uses primary care records. What structured information is recorded and how it's recorded can be affected by a really wide range of factors that include the patient themselves, such as whether they're eligible for prescription charges or not, the particular illness that they're presenting with, healthcare system structures and processes, such as whether the prescription is given in primary care or not, coding practice, and in particular financial incentives for particular codes, and medical, legal and safeguarding considerations in what doctors might be particularly concerned to ensure is well recorded. The detail of this is often very specific to the research question, but the questions remain the same. And we've also seen that linkage to other data sets can help address some of the limitations of primary care records. So hopefully this has introduced you to the rich data set that is recorded in primary care, and also helped you to consider how the context of its recording might be relevant to your study questions using OpenSAFELY primary care data.
Good morning. My name's Stephen Evans. I'm a pharmacoepidemiologist with a statistical background at the London School of Hygiene. We're going to talk now about defining exposure to medicines. Helen has gone through the general structure of GP data, but now we're going to talk about the particular thing that we're often interested in, which is an exposure to a medicine. The medicines can be of enormous variety, and this is a set of the pills from an exhibition in the British Museum that is the typical set of pills that one individual would take during their lifetime. And you can see that there's an enormous range of those pills. So we're going to go through steps of defining drug exposures and identifying the users and periods of use of the medicines. So we might be interested in looking at a steroid like prednisone, and it might be given to a patient with shingles and they have a rash on their abdomen, which is one-sided generally in shingles. So they may be given a steroid as the treatment for this. Now, we've already discussed the idea of the primary care records, and these are the ones that we use in OpenSAFELY, which come from the Phoenix Partnership, who have GP records for more than 2,700 practices across England at the moment. And they also have a very big online database, which contains more than GP records. But we use the GP records from 24 million patients currently. This may expand in the future. So to define the drug exposure, this will depend on the research question. And so an example might be, do inhaled corticosteroids protect against getting COVID-19 disease? And we're interested in defining what are inhaled corticosteroids. We can say it simply, but we need to be very precise when we go to a database. They're used primarily in people with chronic obstructive pulmonary disease, which often follows long-term smoking, and people with asthma. So we might be interested in the research question that looks at the use of the drug and an outcome of COVID-19 admission to hospital or COVID-19 death. So we might be interested in an immediate effect of those drugs. We might be interested in a cumulative effect or a long delayed effect. So our example is there an association in people with COPD or asthma? And we have what is called a cohort study, where we define the drug exposure to start with. And we're a little more precise here by saying it's prescribed an inhaled corticosteroid or a long-acting beta agonist, plus long-acting other drugs known as LABA and LAMA. And this might be a combination therapy. And because we're dealing with GP records, we have that going back in time. And so we are interested in a potential protective effect of these drugs in the 4 months before we begin the follow-up. So having defined the drug, we need to identify the users. Now, the TPP data will have a whole lot of information, and the way that OpenSAFELY works is that we get out data that is 1 row per patient based on the study design. And here we have a hypothetical set of 12 patients for whom we have the date on which their ethnicity was recorded, the date of their BMI, their smoking status date, when they had a high dose inhaled corticosteroid and when they had a low dose one. And we have various dates for these going on to study lots of possible drugs or medical conditions. Now, when we in OpenSAFELY start to identify the users, we use GitHub and we have on there a set of open code lists. And when you go to that open code list, you will see that there are the possibility of finding a whole lot of code lists that have already been set up. So that first one there, the ACE inhibitor medications, contains the medicines that are ACE inhibitors from the blood pressure section that is relevant for the renin-angiotensin system section of the British National Formulary. And so there is a list published there before that. What we can do is we can go and search for anything that says inhaled or inhaler, and we now get a list of asthma inhalers, and we have a code list there for all the ones that relate to a particular drug, salbutamol. And then we have medication codes in the next one for ones generally inhaled corticosteroids, and then we have a high dose, and we have high dose single ingredient and multiple ingredients. And somebody has had to go through and develop that list. And you can see there that it tells you how they were obtained. The NHS Dictionary of Medicines and Devices is a key element for being able to do that. And that is referred to as DM and D generally. So having defined our particular codes for drugs, we then need to identify periods and dosage of drug exposure. And we do that both for single prescriptions and multiple prescriptions. What we have, of course, is that the reality of the database is that it isn't like highly structured data in a randomized trial. It is got missing data, and we may have missing data particularly on the quantity or the dose or the daily dose. But the quantity and dose tend to be well recorded. They are based on the commonly used method for dealing with the missing daily dose. We can use a median daily dose. We can estimate the median daily dose. When we look at the data, there will be particular times in a patient's record when there are different doses of these inhaled corticosteroids or other steroids or indeed any other drug. And you can see that they occur at uneven periods with varying doses. And there might be a gap in the prescription that defines a discontinuation. And so the first gap that we have is one that has quite a long gap that is more than 40 days, probably something like 60 days. And that implies that they have stopped taking it during that time. But here we have a gap where it's rather smaller, and it may be that they actually continued, even though if they were taking it every day, they wouldn't be taking it during the latter part of this period. but you may want to have something that calculates how long beyond the implied end of a prescription a drug might be being used for. So this is a period which we call persistence of drug, a discontinuation, and this will be a period of persistence. So we need to define gaps indicating poor adherence, short gaps, and periods of non-use, which are true discontinuations. So in our example, in the COPD population, the periods of inhaled corticosteroid use said that we needed at least one prescription for that drug within 4 months before the index date, either in combination with a LABA or a LAMA, or as single therapy, provided they also had at least one prescription of a LABA or long-acting beta agonist in the past 4 months. And these were compared for those with a prescription of the other drugs only. So they didn't have inhaled corticosteroids. So this enables us to make a comparison between the use of ICS and non-use. The asthma population don't have quite the same drugs in the background, and there we have prescribed high and low dose or medium dose of inhaled corticosteroids in the 4 months before we begin follow-up, compared with those prescribed short-acting beta agonists only. So the way that we define periods of exposure and dosage will depend on the drug and the studied question. Some drugs will be taken acutely and some will be taken chronically, like inhaled corticosteroids. They're taken for a long time, but it will also depend on the question. Here we're interested in whether this usage prior to the COVID-19 pandemic really occurring, whether the usage of those drugs prior to that might protect people. So we have some limitations. We are dealing with written prescriptions, but not all of the written prescriptions are filled at the pharmacy. And this rate of filling and the rate at which they're picked up from the pharmacy and the rate at which they're taken properly will vary from one drug to another. And there have been studies that have followed that has access both to the prescribing data and the pharmacy data. The other problem is that during the pandemic and with the approach of Brexit, there has been stockpiling by patients of drugs. And we have dates of prescriptions and not dates of dispensing or dates of taking that are recorded in the database. So there are real limitations in this data. The other limitation is that there may be unrecorded drug use. And although TPP has some pharmacy data, we don't always get that data in a particular study. So medicines may be sold in a pharmacy that are on the general sales list, or they may be sold in a supermarket or in a garage. But there are other medicines that are only sold in pharmacies and have the pharmacist present for them to be sold. People may go into walk-in centres and the drug prescription given there, but that may not get back to the GP record. It should do, but it may do. And then there will be drugs given in hospital, which we will almost never know any details of those in the GP record. So in summary, the first step is to define a drug exposure consistent with the research question, and we need to look at mechanisms of action. And then we have to identify the users of the medications. We need to make sure that we have a full list of the products and therapies that we're dealing with. And then we identify periods of exposure and usage. And this has to be done for single prescriptions and multiple prescriptions in a different way. And there's a reference there to a paper on that. Thank you very much.
Hi, my name's Kevin Wing, and I'm an assistant professor of epidemiology at the London School of Hygiene and Tropical Medicine. And I'm just going to be talking about defining clinical outcomes in OpenSAFELY primary care data. So first of all, some key considerations about outcomes. Some outcomes are much easier than others to study using electronic health record primary care data. Those that are easier to study tend to be outcomes that are clearly defined, perhaps you know them as harder outcomes, and may be relatively straightforward for a clinician to diagnose or for a GP to diagnose. Those that are more difficult to study are outcomes that are perhaps less well defined and may be more difficult to diagnose within primary care. You also need to consider whether the diagnosis of the outcome actually may have been made outside primary care. So for example, if it was made by a specialist in a hospital, what impact does this have on, first of all, when the diagnosis is going to be entered into the primary care record, and second of all, the level of detail that might be entered into the primary care record. So I'm just going to talk about some examples then in relation to that. So on this slide at the top, you've got outcomes that are easier to study using primary care electronic health records. And then this moves down to the bottom. You've got those that are more difficult to study using primary care electronic health records. So at the top, what I've put is serious liver injury. So within electronic health record primary care data that's within OpenSAFELY, so you do get laboratory test results that are available. And for serious liver injury, you can get liver function tests. They're available. And also there is a defined external laboratory criteria for defining something like serious drug-induced liver injury. So those criteria exist and are quite clear. So that's a relatively easy outcome to define. Then move down just to getting a bit more difficult. You've got chronic obstructive pulmonary disease exacerbations. So these exacerbations, there is no laboratory test, unlike for serious liver injury, but diagnoses of these are often recorded by the GP. And in fact, that diagnosis with electronic healthcare records in primary care in the UK has been validated. And I'm going to talk a little bit about what that means on the next slide. Then we move down to epileptic seizures. So with epilepsy, first of all, epilepsy requires a specialist diagnosis. So the diagnosis of the condition won't actually be made by the GP. There is not yet any validation work on any diagnosis that has been entered into the primary care record. And the other point is that in relation to seizures, in fact, if you look in primary care, that the type of seizure that somebody had is very poorly recorded within primary care. So that all of those make that a more difficult outcome to study. And then finally, we've got onto something like chronic fatigue syndrome, so ME/CFS. So that will often involve a lot of contact with GPs, so it can take months to diagnose. It will also likely involve multiple specialities, so external to the primary care, so secondary care specialities. And unfortunately, there are a lot of different definitions. So all of those things mean that that is really quite a difficult outcome to study within primary care records. And you just have to think carefully about how you're going to do that. So I mentioned validation, and what I mean by that is, has there been any work done to show how the recording of that outcome within primary care electronic health records compares to a gold standard? Okay, for example, what percentage of the people that are identified as cases in OpenSAFELY primary care data are actually cases compared to a gold standard? And that gold standard is usually external to the primary care data. For example, that can be questionnaires to GPs or patients from a sample of the data. And in fact, OpenSAFELY technology includes the ability to a mobile app, so you can push out questionnaires for additional information from a sample of patients. Or the external source might be other linked data sources. So the data might be linked to specialist registries, or there may be a survey of patients that has been performed that has been linked to OpenSAFELY. So how do you go about then defining your outcome, particularly within OpenSAFELY? So you need to know about outcome code lists. So all clinical diagnoses that are recorded in OpenSAFELY primary care are linked to specific codes. And in order to define your outcome that you're interested in, what you'll first need is basically a list of those codes, okay? And there are a number of different coding systems. For example, SNOMED or READ CTV3, okay? And what OpenSAFELY uses, the primary care codes that they use, they're currently based on the CTV3 or the READ coding system. So here's a high level overview of the process that you would follow if you want to prepare a code list for your outcome of interest. So first of all, you would check for existing code lists, and OpenSAFELY publishes all its code lists that it uses on an open access website. So if I click on this link, this should take me to OpenSAFELY code list. So what you see here is all the code lists that there have been used in studies so far, and these are alphabetically organized. So you just go down, okay, and you can just have a look down to see the one that you want. And what you'll see is, as well as you'll basically see the title of the code list, and then a brief description of what it is, and then the type of coding. So here we've got the CTV3 code that I mentioned. So if you search the code list website and the code list that you want isn't there, then you would need to prepare a code list yourself. And the way to do that, you don't just prepare the codes without any sort of understanding of what they mean. First of all, you prepare a list of clinical terms, okay, that you're interested in that relate to your outcome. And for this, it's important to get input from a clinical expert in the area you're working in, or to look at if there's any published studies that have code lists that you might want to adapt. Once you've prepared this list of terms, you can then use, OpenSAFELY has a code list builder, which is very user-friendly to convert the terms into codes. And then you would then upload that code list to the website I just showed you. And what that means is onto step 3, and you can then include your code list in your OpenSAFELY study definition. Okay, and so that's a file that defines everything, all the data that needs to be included in your study. And it will also list all the code lists. So you would add your new code list to your study definition. And what that means is that you can then apply those lists of codes related to the clinical terms that you know about to all the people in OpenSAFELY, and you could select people based upon that outcome. So here I've just got a screenshot of the OpenSAFELY code list builder. Again, so this is available if you're doing a study within OpenSAFELY, but actually this is code list builder can be used by anybody. It's available on the web. And the first thing you do is to create a new code list. So here's new code list specifying the coding system. And the example here is a code list for COVID-19. And the coding system is CTV Read version 3, which is what is used in OpenSAFELY. You would then click create. And after you've clicked create, you get taken to another page. And here, so there's a second bit on this slide, it's basically you add your terms to search on, selecting those you want from the term results. So what I mean by that is, so I've put some search terms in here. I've put COVID and SARS, and I've highlighted the COVID one. And when you click on it, you basically get a result of all the codes within the OpenSAFELY dictionary that exist, and you would select the ones that you want. Okay, so here's the buttons for selecting them. And then you can add them to your code list. And then when you've finished, you export that, and there's the way of then uploading it to the web page that I just showed you, which means it will be available for use in your study. So then the final point I want to just talk about is related to how complete is my outcome if I'm just using primary care records. And there's quite a well-known study that looked at myocardial infarction as an outcome, and it looked at 4 different types of data in the UK. It looked at primary care data, so that was actually in the Clinical Practice Research Data Link, or CPRD. It looked at hospital data in the Hospital Episode Statistics database. It looked at disease register, so the Myocardial Ischemia National Audit Project, or MINAP, and it looked at mortality data in ONS. And in that study, what they found was that if you look in each different source separately, you get a different frequency of myocardial infarction recorded. And so the first column here is ONS, then the second is MINAP, the disease registry, the third is hospital admissions, and the fourth is primary care data. And you know, you wouldn't expect that these would all be similar, because obviously ONS is just death, so that's the most severe myocardial infarctions. And then you've got the disease registry and primary care. You may have different recordings there. And hospital admissions, you may have people who go straight to hospital, and you know, might not, for whatever reason, it might not end up in primary care records. So it's not really surprising that there are differences there. But what the authors then did show that basically, if you start to combine the data, and particularly in the last two columns, where the last one is combining primary, secondary, and registry data, and the second last one, and the final one is combining primary, secondary, registry, and death data, is that you can really increase the frequency you get a complete picture of all the everything, all the myocardial infarctions that occurred. And so the conclusion is basically that really you need to be careful when you're performing studies that ideally use linked data wherever possible. But if you're not using linked data, then you need to consider that when interpreting and reporting your results for your study. So just to summarize some key points, first of all, I said was some outcomes are easier to study in OpenSAFELY primary care data than others. And you need to think really carefully about the outcome and whether it is actually possible to study in primary care. Ideally, what you want is a validated outcome. So that's where somebody previously has published something to show how well the outcome recorded in primary care performs against a gold standard external source, or if possible, try and use linked data or use linked data. So in OpenSAFELY, you can, for example, you can link from primary care data to secondary care data. Then if you have to prepare a code list within OpenSAFELY, so first of all, you check the OpenSAFELY code list website for the public to see if it's there already. If you need to prepare a new one, then OpenSAFELY has defined processes and a very user-friendly code list builder to assist in this. And then once you have a code list for your outcome, you can then use it within studies to select people in OpenSAFELY who have the clinical outcome of interest. Thank you very much.
Hi, my name's Ian Douglas. I'm a pharmacoepidemiologist at the London School of Hygiene and Tropical Medicine. And I'm just going to give you a brief talk about how we use exposure, outcome, and patient information that's recorded in mostly primary care data to be able to do research studies in the OpenSAFELY platform. Okay. So what we're going to cover in this is how we turn these electronic health records into answers for a research question. I'm going to take you through a few of the main steps that are involved. It's going to be based in a worked example of a study that we did earlier this year, and it is by no means exhaustive. It's just to give you an illustration of how we use these data. So the question that it's based in is a study we did earlier this year to look at whether or not exposure to inhaled corticosteroids was in any way protective for COVID-19 related outcomes. So the research question here is all around this exposure to inhaled steroids. These are treatments used by people mostly with asthma or COPD. And we wanted to know whether or not exposure to these treatments led to better COVID-19 outcomes. And we wanted to know if this was a causal effect rather than just something that may happen more in people who happen to be taking inhaled corticosteroids. And for us to establish whether this might be a causal effect, it means that as well as knowing about whether people are taking steroids and whether or not they have a COVID-19 outcome, we also need to know lots of information about other characteristics of these patients, such as their age, sex, smoking bit patterns, other respiratory diseases, and other comorbidities that they might have. So for us to answer this research question and for us to use primary care and linked data to do it, we need to be able to get all of this information from the patient record. So we need to know, for example, whether or not people have asthma or COPD, whether they're aged more than 35 years. We need to know whether or not they're exposed to inhaled steroids. We need to know if they could have had the outcome, death due to COVID-19. And we need to get information on lots of other factors to do with these patients, which we call confounders, to see whether they might account for any differences we see between people exposed and not exposed to inhaled corticosteroids. So the data that we used for OpenSAFELY was primarily UK primary care data, and this was available from primary care practices using TPP software. And this is about 40% of the UK's population. It's a very rich source of data which gives us information about anything clinical, prescribing, demographic data that's recorded for patients within these practices. These data are also linked to other non-primary care data sources, and I'll talk about one of these later on. What's really important for you to remember is that none of these data are collected primarily for research purposes. So the data are collected for GPs to keep a track of their patients and to keep good records so that they can give them good care. It's a happy coincidence that we can also use these data to answer research questions, but I would say that it's probably about 80% of the work of an epidemiologist using these data is around how they handle the data, how they query it and make good use of it to be able to answer these research questions. So it's a lot of work to turn the data into useful data to do analysis on, which I'm going to briefly outline for you in the next few slides. So the sort of data that we want about patients are all routinely recorded in general practice. It's things like their year of birth, their sex, when they joined the practice, when they registered, when they left, or when they died, things like their ethnicity, and then also their socioeconomic status. Of course, GPs are recording a lot of clinical data about patients, and this captures anything important that's clinically relevant and that's entered by the GP. And this is typically contained within structured fields within the electronic health record, containing things like the date the event was recorded, and then using a special code system, either CTV3 read codes or SNOMED codes, to record what the clinical event or piece of information is. We also have extremely good therapy or prescribing data. So whenever a GP prescribes a medication for a patient, this is captured electronically, and all sorts of useful information about the prescribing is captured. And this includes things like the date the prescription was given, the code, the Dictionary of Medicines and Devices code that corresponds with that medication, the quantity, other useful things like the number of daily doses and the pack type, all sorts of things that we might be interested in getting to turn this therapy data into useful information for our research. Now, this next slide is really busy and I'm not expecting you to read it all, but what it illustrates is a timeline. So the time runs horizontally across this slide, and it shows the timeline for the study that we've designed, and it's anchored. Hopefully you can see the cursor moving here. So we have an index date at this point, which is the 1st of March 2020, and we anchor our study population around this date. This is the start of follow-up, and beyond this date, we're going to look to see whether or not people have outcomes in the future. But we're going to use the medical record to look at what happened before this date, and we're going to use it to assess whether people should be included in the study, whether they should be excluded, whether or not their exposures can be captured, and whether we can then put them into the group of people with or without steroid exposure. And we're also using this information to capture their covariates, so things like their age, sex, and comorbidities. I'm going to demonstrate this in a bit more detail on the next few slides. So first of all, this shows you part of how we might assess whether somebody should be included in the population in the first place. So here we're interested in whether or not patients have had a code for asthma. Now, we wanted to know whether patients had a code for asthma in the previous 3 years before the 1st of March 2020, because this meant that we would be confident these were patients who had currently active asthma disease. So you can see the patient I've illustrated here on this timeline does indeed have a code for asthma within that 3-year period. Now, of course, we also get the rest of their medical record. So it's possible that they could have had a code for asthma before this time, or also subsequent to the 1st of March 2020. These records subsequent to and much earlier are not relevant for assessing whether the person should be included in the population. But this record here within the 3-year time window is really important, and it allows us to include that person as a patient with asthma for this study. If we'd have seen a record like this, so a person with no record of asthma before the 1st of March 2020, but a later record for asthma, this wouldn't get them included in the study because the record wasn't happening, wasn't dated within our 3-year time window. Also, I've shown on these slides that we're also assessing the age of the patients on the 1st of March. And you can see this patient here was aged 67 years. The patient I showed you before was aged 52 years. So again, this is another reason why this patient would be eligible for inclusion, because they're aged over 35. We're also using the medical record to assess the patient's exposure history. So here I'm showing you a longitudinal record of when a patient might have been prescribed an inhaled corticosteroid. And for our study, we were interested in whether they had a record within 120 days before the 1st of March. And we were taking this to mean that the patient was probably exposed to a steroid from the 1st of March onwards. You can see in this example timeline, this patient does indeed have a steroid prescription within that 120-day window. And that means that we would classify this person as being exposed to a steroid. You see an example for another patient here, where you can see that they had a prescription for an inhaled steroid earlier, so before the 120-day assessment window. This wouldn't allow the patient to be classified as being exposed, so this patient would be included as an unexposed patient to steroids during the period of time we're interested in, from the 1st of March onwards. Again, here's another patient who just has no prescribing of steroids at all. Again, this patient would be included as an unexposed patient. I mentioned that we're also interested in assessing patients for all sorts of covariates, including their medical history. And for example, we were interested in whether or not people had heart failure before they entered follow-up on the 1st of March. And to do this, we were interested in looking at the entire medical history of the patients up until that point in time. You can see that this patient has a history of heart failure. They had it recorded at some point before the 1st of March. So we would include this person as having a history of heart failure. So coming on to assess the outcome, we were interested in whether or not people died from a COVID-related cause after the 1st of March 2020. And to do this, we relied on linked data from the Office for National Statistics, and we were looking specifically on the death record for these 2 ICD-10 codes, COVID-19 with the virus identified or COVID-19 with the virus not identified. So anybody in our study population who had either of these codes between the 1st of March 2020 up to the 6th of May 2020 would be classified as having died of COVID during our study follow-up using these linked data. Okay, so that was a kind of a rush through how we use the medical record to be able to identify these really important pieces of information that then allow us to do our analysis, comparing people exposed and unexposed to corticosteroids to see whether or not they had a difference in their COVID-19 related death. Now, we run a whole series of analyses, and I don't expect you to be able to read this slide, but what I'm going to highlight to you on the next slide is just this top panel here. And this was the main analysis we did amongst people with a history of asthma. So here you can see the results comparing people with, so it's the second row of data here, shows you the people who were receiving low or medium dose inhaled corticosteroids. Below that, we have a separate stratum, people receiving high dose inhaled corticosteroids, and we're comparing them against the people in the first row of data who were not receiving inhaled corticosteroids, but did indeed have asthma. So in the first column here, you can see the number of patients that we identified within each of these strata. So we're looking at very large numbers of patients here. We've got 108,000 in the baseline comparator group, 600,000 exposed to low or medium dose steroids, and 100,000 exposed to high dose. The next column shows you the number of people who experienced a COVID-19 related death over the follow-up period. And then we compare these groups with each other to give us a hazard ratio, which tells us whether or not the patients in the exposed group were more or less likely to experience this outcome over follow-up. This crude hazard ratio column tells you what happens, what the comparison was when we don't adjust for any differences between these groups. And you can see that in both of our steroid exposed groups, we saw a higher rate of death than in the unexposed group. And then the final column shows you what happened once we'd adjusted for all of the differences between these patients, such as age, sex, and all their comorbidities. And you can see that there was, for the low or medium dose exposed group, there was very little evidence of a difference in the risk of COVID-19 death. What we did see was a slightly increased risk of the outcome amongst patients receiving a high dose of inhaled corticosteroids. What we think is that this was actually due to other unadjusted differences between the patients. We don't believe that there was a causal harm due to receiving inhaled corticosteroids. And in fact, we believe that there was no difference in the rate of COVID-19 deaths amongst people exposed or unexposed to corticosteroids. So to summarize, the use of EHR data to do research is very helpful, very useful. We need to have a very clear question at the start. We have to define what the research question is, and then establish whether or not we can use EHR data to answer that question. And so first of all, we have to think through all the reasons that those data exist, remembering that they don't exist for us to do research, but it's a happy accident that we can use them to be able to answer these kinds of questions. We need to think very clearly about whether we can capture the exposure, the outcomes, and the covariates that we think we'll need to be able to answer the research question. It's often the case that a linked data source will be able to supplement the primary care data record. And you can see the example we used here, specifically ONS death data was vital for us to be able to do this research. We have to make a very wide range of assumptions and decisions along the way in terms of how we handle the primary care electronic health records to turn them into these analysis data. And we have to give a detailed description and justification for how we do this along the way. So I hope that was helpful. That's all I'm going to say on this, and I hope this has been useful.